Doctors with disabilities exist in small but measurable numbers. How did they navigate their journey? What were the challenges? What are the benefits to patients and to their peers? What can we learn from their experiences? My name is Lisa Meeks, and I'm thrilled to bring you the Docs with Disabilities podcast. Join me as I interview docs, nurses, psychologists, OTs, PTs, pharmacists, dentists, and the list goes on. I'll also be interviewing the researchers and policymakers that ensure medicine remains an equal opportunity profession. Welcome to our Association for the Study of Medical Education, or ASME, episodes. I had the distinct pleasure of recording 2 episodes of the Docs with Disabilities podcast at the 2024 annual scholarship meeting in Warwick, UK, where this year's theme was Your Key to Maximizing Potential. It was an absolute honor. In this episode, the second in the series, we discuss navigating disclosure and accommodation requests when you have a non-apparent disability. Our discussion delved into the structural and climate-related barriers that medical trainees with non-apparent disabilities face. However, the conversation went way beyond these challenges and explored the unique privilege and peril of having a disability that may not be apparent to others. I want to offer a brief trigger warning. About 3/4 of the way into the episode, the topic of suicidality comes up and is discussed in a very direct manner. It's important that we're able to discuss these topics in an open forum and acknowledge the pain that often parallels medical training. But if this topic is triggering for you, we suggest forgoing this episode. Your health is our priority. For those listening with non-apparent disabilities, we know you'll find common ground in the experiences shared by our guests. For those without disabilities, especially faculty and leaders, we hope this episode provides insight into the challenges faced by disabled doctors and learners navigating your training and practice spaces. And now, let's meet our guests.
Hi everyone, I'm Dr. Megan Brown. My pronouns are she, they, and I'm a Senior Research Associate in Medical Education at Newcastle University.
And hello everyone, my name is Dr. Joe Hartland. My pronouns are they, them. I'm a Senior Lecturer and the Deputy Education Director at Bristol Medical School.
So to start, I have to say that the more I do this work, the more I see the research outcomes. I think, we kind of said the privilege and the peril, really, of having a non-apparent disability. Can we break down, perhaps, some of the things that might be considered a privilege of having a non-apparent disability?
I mean, my experience with disability is a very long process of it, even accepting the term and as it applies to me, despite having had multiple surgeries and 14, 15 years of some of the issues, lifetimes of other ones. And I think for me, because my disability varies from being either hidden or not hidden, depending on, and we've sort of spoken about this before, but for things like fatigue levels and stuff, it is interesting the way people treat me differently depending on how increasingly visible something is or not something is. And we spoke a little bit about this yesterday or the other day, Megan, which that idea of like how people sometimes, if I'm thinking about like my experiences as a queer person, like pass, if you like. So like to be able to pass and not be spotted as someone who's disabled, not have to be the recipient of that stigma, but also like as that becomes more obvious, there's often this kind of like, oh, are you having like a bad day? There's often like a lot of stuff that's put on you about that, about, well, just because my disability is more obvious today doesn't necessarily mean my day is bad. But there's a lot of weirdness that comes in opposition to the privilege, if that makes sense. So like the transition phase is weird.
There's so much weirdness. This is my first ASME conference using my mobility scooter. So I've used it at other conferences, but there are obviously people that I only know in this space that I would only see at this conference. And I have had a lot of, are things worse? I've already got, so I have both visible and non-apparent disabilities. My visible disability means I use a walking stick and sometimes my scooter. But even that, just like perceived, the scooter as an aid must mean things are worse. There's a perception and there's a stigma there around then being an ambulatory scooter user as opposed to being just kind of mobilizing using the stick. So I would say, yeah, I've definitely experienced that even within the sort of the experience of this conference. There's a privilege to being a walking stick user as opposed to being someone who is using a mobility aid such as a scooter.
And you've had all experiences. You've not used a stick.
Right, yeah.
Then began using a stick.
It took me a long time to accept using the stick. I wasn't that non-apparent because I don't walk well without the stick. But I had a lot of internalized ableism and my own ideas around negative perceptions and worries about using the stick. And when I use the stick, I get a lot of comments, what have you done? It's like, I have a custom walking stick. You think for a twisted ankle or a broken leg, I've spent like hundreds of pounds on this beautiful, that I'm really proud of. Yeah, you get a lot of that. My other non-apparent disabilities, so I'm autistic. For a long time, I've had mental health problems, which were probably misdiagnosed, were probably autistic burnout, but not known as such at the time. And it is different because you are constantly making decisions about how much of yourself to show, I think. And sometimes when you're with people where that is great and comfortable, it's great. There are moments of community and bonding, and in some ways it's a privilege to have been able to find those people and find those spaces. But equally, it's very tiring. So after every person that you see sort of weigh up, should I visibly be stimming? Should I be, is that okay? Are people going to think that I'm being like really fidgety and weird and not listening to them? How much eye contact do I need to be making with someone? Are they going to think I'm not listening? All of that's like takes a lot of effort and energy.
Yeah. So my experience with so it'd be easier if I get some context. So I have arthritis in my hips, which is the result of deformity in my hip joints, and I've had a lot of surgery on those. It was discovered when I was a medical student. It was that awful, like, oh, would you mind being an examination in front of the class? And then the surgeon being like, well, that's not normal. And I think we've spoken about it before, that the surgeon then spoke to me afterwards and said, do you get a lot of pain in your joints? And I said, yeah, like just like everybody does at the end of the day. And he was like, well, not at 20, no. And I had for years lived with pain in my joint. It didn't even occur to me to mention it to anyone because I just thought everybody hurt all the time. And so that was like a moment of realization for me around that. And then I've kind of come to terms with similar moments of realization more recently around neurodivergent diagnoses and experiences where I've been like, what do you mean you find that easy? What do you mean that that's the way that you navigate the world? How, what, absolutely blowing my mind that people have these different experiences. And so some of that, and my very prolonged history of obsessive compulsive disorder and depression, they've all been visible and less visible at different times in my life. But I think one of the things that is really interesting is how with like, especially the mental health and the neurodivergent element, once it becomes visible to people, like that label stays with you, whether you're well, inverted commas, or not, whether you're currently experiencing symptoms associated with that diagnosis or not, or whatever, it always feels like it's there in the background. So I think privilege is a really interesting conversation when it comes to these things that are less visible, because I think once they're out there in the world, people don't often let you forget it. And so they kind of stay with you for a very long time. So I do think I can experience a lot of privilege in newer spaces, depending on what I want to share and what I don't want to share. But I think I'm at a point now where I'd rather sacrifice some of that privilege to just be myself. to just be able to be like, if you're going to stigmatize me, I don't care. Like, if you ask me how I'm feeling today, I'm going to give you a really honest answer. And if you can't deal with that, don't ask me how I feel. That's not my problem. I think I'm probably at the point now of kind of handing over some of that privilege and being like, I actually don't want it. Like, this privilege comes with a cost, and that cost is a lot of me being invisible. So I've been trying to figure out how much of that I want to keep, and it feels very similar to my experiences of being a genderqueer person. And you know, if you are someone who has been assigned male at birth or has presented masculine most of your life, once you take on more feminine identity and express that, you very rapidly realize how quickly you lose the privilege of masculinity and how quickly people will treat you in a misogynistic way depending on like what femininity you present. So there's an interesting comparison to me between the two experiences of like moving from privilege to not privilege and navigating it.
It's really interesting because I think there's a significant cost to masking. There's also a cost to unmasking. Mm-hmm. So some of the spaces that I've been in and where I've known people, and so I'm sort of probably known for a long time that I'm autistic, but have had the official sort of diagnosis, bit of paper, whatever, that you don't need to be validated and to identify as autistic, but has been for me part of that process of coming to terms with my identity and what that means for me and how I navigate the world. And being in spaces where people have known me as somebody who has been masking, it's not always a conscious decision now to unmask. I feel like now I've begun the process of trying to sort of reckon with myself, like, this is who I am, and actually these are the things that help me and are going to stop me from getting myself in the position where I'm like super burnt out again and become unwell again. It's like once I've begun to peel off the layers, sometimes more falls out, and that's not always like within conscious control. And where people have known me to mask, I overcompensate sometimes. So I'm like, I try like strong smiling and like trying to be like really happy with people is often a sign, especially when they're unfamiliar people, of me masking. But then to suddenly be not doing that, what's wrong with Megan? Is she, she's upset with me, she's annoyed with me, she's being too direct. That's and not, had I been like that all along, maybe they would have been like, but that's fine, that's who she is, that's the way that she is. But the contrast and the fact that like once I've started to unmask, it makes you feel like, are people going to be annoyed at that? So I think it's both ways. There's a cost. Mm-hmm. So it's really challenging to decide how to navigate that. Yeah.
I was going to tap into the masking, so I'm so glad that's where you went with it. The idea that while it might afford you some privilege in a space, it is also taking a toll on you to do that and to navigate that. I hadn't thought about what happens when you unmask, and then that's another level of toll. Yeah. I'm sitting here thinking about what both of you have said about the need to explain behavior or choosing to be authentic and having people come up, are you okay? Are you okay? And part of me is like, isn't it great that we're asking each other if we're okay? And then yet, like I can see how this would be really exhausting. But you might be thinking, it's easier to mask. And then you try masking. Right. I asked if it was easier to unmask in personal spaces and harder in professional ones, which brought up memories of navigating the clinical setting. While Doctors Hartland and Brown are no longer practicing clinically, they recounted the multiple disability-related barriers that led them to leave clinical practice.
I think the circumstances of employment in the NHS made it so that even saying, I honestly don't know how people can navigate the system sometimes, because I had my arthritis was diagnosed when I was 20, and I was awaiting my 4th hip surgery, and I was working in a hospital, and there was a car park in this hospital that we had to park in as staff. Obviously, you had to pay for it as well. And it was basically like a gravel pit. And it was full of holes and like, and I had not a bad fall, but like I was using a walking stick at the time and there was a hole and it was after a night shift. And so I like went to occupational health and they said, oh, you can park in this car park that is closer to the hospital. That's one of the accommodations we'll make for you. But every 3 weeks, we'll need you to prove that this is still going on. And I was like, I mean, it's been going on for 12 years. I don't know. And they would literally, if I hadn't done it, not raise the barrier if my like time period had run out. And that was just to park my car. So like to try and navigate unmasking other things that that are harder possibly to like create reasonable adjustments for within a workplace, that is often quite chaotic, is very noisy, is hard to control. I don't know how I would have struggled, how I would have done that. And leaving the NHS was in part because there was such a lack of compassion for that kind of stuff.
I found it incredibly combative. Like it was, so when I first made contact with sort of support services when I was working as a doctor, it was a picture of sort of serious mental illness. Again, didn't know it was autistic burnout because I wasn't diagnosed properly. But I was treated as a danger. I don't believe I was a danger to patients. I've never had any concerns about, like, I've never been through any fitness to practice or anything like that. But because I had this diagnosis and I made contact with services, it was, oh no, it's dangerous. I remember there was one occupational health consultant. Every time I went to see them, we would write the letter together, right? So this is supposed to be like a co-produced output from a collaborative conversation. It consisted of them sitting behind a desk and me sitting in silence for about 45 minutes. This guy was the slowest typer you would ever meet in your life. And it was just shocking. I was just sat there like, what is happening? How is this helping me? This system, this process just isn't helpful. And at that time I was struggling to do much. I was sick, I was off work. Part of being autistic is I hate phone calls. I hate them. I can't make them. I've like really like a lot of like social anxiety around like initiating a phone call in particular to somebody that I can't see on the other end of the phone, can't see how they're reacting and responding to me. I find that really tricky. And like if you can't make these simple phone calls or do these kind of simple administrative tasks, you're not well enough to be at work. It's like, no, it's different. Like it's very different. But like, being sort of assumed that if you can't carry that extra load, that extra sort of burden, the administrative burden of unmasking, then you're not okay. Or you're not permitted to be in that space.
I haven't thought about this for years, but I just had a memory of, with occupational health, like me and occupational health have a really weird history together, both in my current roles, like asking them to be inclusive of other identities. But I remember I started at a new hospital and I had declared on my occupational health form, like beforehand, the ongoing problems, that I was awaiting surgery for my hip, that I had mobility issues, that kind of stuff, as well as a history of depression. And they said, oh, you need to have an appointment with occupational health. And I was like, okay, like fine, like not a problem, I guess. Like, sure, I'll do that. And they phoned me up and they went, so we just want to make sure, are you currently depressed or are you not? And I was like, not right now. And they were like, okay, that's all we needed to know. And I was like, oh, nothing else.
Oh, that was the appointment?
That was the appointment. There was no other accommodation discussions. There was no other support discussions. They just wanted to check, like, was I too crazy to be near patients? That was basically the vibe I got from them. And yeah, I haven't thought about that for years. Like, I haven't, literally just occurred to me, like, one of those many little injuries you get, right? You're welcome to the trust.
Paper cuts.
Yeah. Well, I hadn't thought about that.
You call it an injury, I'm going to call it something else. I think it's a signal. I think it's a signal to you that when and if you are depressed, this is not the service that you want to engage. because that sounded very much like a policing question and a policing response, right? And to Megan's point, I think you felt very policed.
Oh, yes.
And regulated.
Yeah. It wasn't it's not a process in my mind for the doctor or for the person seeking support. It's for patients, in inverted commas. Yes, obviously, we want patients to be healthy. We want them to receive the best care they can. But I think sometimes that is used as a way of justifying an organisation's mission and aims. This is about patient safety. Therefore, we can police and regulate you.
And there's a lot of assumed incompetence, right? Like there's a lot of, I mean, we spoke about this earlier in another presentation that we did, but this idea of like a lot of the guidance that regulates the inclusion of disabled people in the workforce and in education in the UK and by the General Medical Council has as a theme running through it an assumed disruption to service and an assumed lack of competence of those individuals.
And lack of productivity.
Had a high-level meeting with at GMC level with leaders of foundation programs and occupational health from the UK recently, and an occupational health doctor said in that meeting about how we had to be cautious about the inclusion of disabled people because it's already hard to staff night shifts as it is. So, we don't want to be just admitting loads of people to the workforce for whom we're going to have to keep accommodating for. And I said, well, I think the reason you're struggling to staff your night shifts is because you're a bad employer. It's nothing to do with disabled people's inclusion. So I think we need to shift the premise of that argument and just stop talking about it, because I was so affronted by the accusation.
But the systems, and I mean, it's writ large, but health systems, they're built on productivity and growth. They're not built on community and connection with other people. It's all about getting bigger. It's all about the bottom line, isn't it? And I think it's connected to that. Like, I don't think you can separate disabled people, disabled doctors and their experiences and their rights from that kind of, I don't want to get too political necessarily, but the kind of the capitalists. No, but right, like it is burn it all down.
No, but it is capitalism, right?
Yeah,
it is to do with
capitalism.
productivity. It is to do with the value that we place on lives and people and what we think is of worth, right?
Where value lies.
Yeah, 100%.
We often think of disclosure as an all or nothing decision, but it can actually be on a sliding scale, especially for those with multiple disabilities. There's also the concept of drive-by disclosure, where you casually mention something to test the waters, engage the response, and the safety. I asked our guests to share their experiences and thoughts on navigating this delicate balance of disclosure. When did they feel the need to flip the switch, and what impact did it have on their professional and personal lives?
Yeah, you do that in my partner.
Yeah.
Look at them, bit of side eye. Well, how did they respond to that? Okay. Sorry.
No, I love it. I think we should all refer to partners as partners, and just the whole world. Just I guess.
I also wanted to contextualize why I laughed when you were saying about the hidden element, because the other thing I realized is I think some of the stuff I do is hidden, and I don't think it's that hidden. I think it's what I suddenly twigged as you said it, that I remembered a student saying to me, we were talking about they had been struggling because they couldn't get their ADHD medication, and we were talking about that and getting some chat. And then I disclosed, I said, my therapist has been, exploring some of this with me, so I can understand how difficult this must be. And my student went, I have been wanting to say that to you for so long. And just that idea of I think sometimes we think we're hidden, we think we're masking and all that kind of stuff, and I don't know how often we...
But I sometimes as well as those shared points of connection as well, isn't it? If you, as an autistic person, I feel you're just, I don't know, it's sort of sometimes gravitate towards each other. I think we're more visible to each other, maybe, as well.
Yeah. Sorry, I interrupted your line of questioning.
No. So I just wanted you to reflect on whether you had that kind of lever pulling, flip switching moment where you thought, I have to do something. Megan, it sounds like for you, maybe it came to a head.
Yeah, no, it really did. For me, it was a sort of like, it kind of relatively sudden, I guess, and no other choice, I guess, at the time, because I was sick and I was off work and I needed to be off work. And then once you're off work, there are questions. What's on your sick note? What has your doctor written on your sick note? And then, how do you go about getting back into the system once you're out and you're sort of, you're deemed sick and you get that label of someone who is sick. And I wouldn't have considered myself disabled at that time. But for sure, with that sort of initial experience, it was, explosive maybe is probably the right word. Like it did sort of blow things up for me and make me reconsider. And it's ultimately what led me to sort of career shift into a space that is better for me, admittedly. But, still has its challenges, obviously. So that is what sort of accelerated or put that sort of process in motion. Other things, it's like, I often say to Joe, I'm in favour of like a soft launch. So the way that it's not the best, but I'm kind of awkward and I never really know how to like drop it into a conversation with someone. So like and I feel bad about doing this sometimes, but even like with close friends, I will sort of just like put it in my bio on social media. Like it's pretty, like put it in my email signature that I've changed my pronouns. Just sort of wait for people to like notice and ask me, because I have difficulty initiating telling people about that, let alone then going and getting the sort of the accommodations at that kind of like institutional or organizational level. So yeah, it's been a soft launch for everything else. Obviously the visible disabilities is different because, people can see and ask.
I'm not very good at soft launch.
No, I know. We've different styles.
I'm a hard launch a lot of the time. I think it's different times, different issues, different switch flips, I guess. Yes, I've had those moments of intense, I assume probably noted in this space already, but a little bit of a content warning, suicidality, something that I'd experienced kind of every day from the age of like 13, 14 into my early 30s, but a few times coming to peaks. And yeah, those moments of total lack of safety, right? Like, actually, this is now no longer safe for me or anyone else. Like, yeah. But also, how many of those switches are maybe flipped like without my permission? Like, how much information shared? Because I was just thinking, as like a rotational trainee, often like things follow you and like reputations follow you as well. So the idea of like needing time off or like struggling with certain issues, being someone who challenges or asks for support or like dares to question why something is the way it is, follows you around. So I don't know how often switches are flipped without me ever being aware. Like, it was never me that flipped it. I've gone into a space and I've already been classified and quantified, and this is now who I am. Whether that's to be with being the problem-making queer or the person who asks for accommodation or whatever. I don't know how much control I have over it anymore.
We call it forward feeding in the US. I think it's done with good intention, as so many things are. However, I've had students tell me, I can tell when someone's been told about my disability. There's a palatable or measurable something in the air when they know that I'm leaving for therapy every week. And there's a judgment oftentimes that goes along with that. And I think along with the judgment of someone leaving to do something when they have an invisible disabilities, where there's a very clear demarcation. This is acceptable in medicine, this is not acceptable in medicine, or something I can measure or test, right, with a blood test.
I was curious about our guests' experiences dealing with the perception of the disability con. So I asked them, have you ever felt like people were questioning your motives, thinking you were gaming the system, asking for accommodations to get ahead or to avoid something? Here's what they had to say.
Oh, God, all the time. Yeah, all the time. I'm constantly worried about being seen as flaky, like being seen as someone who doesn't turn up, or who I love like work. It's really sad to say that, isn't it? But I love over committing myself to things. I love ideas. I find them exciting, and so sometimes I will take too much on, and then that is my own process of working out what I can and can't sort of deliver on. But yeah, I'm always worried about not being seen as not being able to. My job is great, but I'm a little drive away from my job, and so it is a bit of a commute. If I have a bad day, I'm not going to be able to do that, but how will that be seen? And I've actually no evidence within my team that would be seen badly, but because of prior experiences, that sort of maps onto that. And then with the sort of coming to realize that I'm autistic, one of the things as I've started to learn what that means for me and embrace more elements of my identity, why are you like suddenly more autistic now than you were? So it's almost like, has someone like put that idea in your head and now you're just like leaning into it as, I don't know, as a way of
Someone's been on TikTok.
Right, yeah, like it's a fad, like it's a fad or something, but rather than it just being like, well, actually, no, I get it now, and I actually I can explore what that means and what that looks like for me. But yeah, those perceptions are just, I think they're everywhere. They're everywhere.
Yeah. I think interestingly, I've had that less with mental health. And I wonder if it's because when my mental health is bad, it's really obvious, if I'm honest, like the flatness, the mood shift, the lack of it. Like I read as someone who's unwell. Like it's not very easy for me to hide once it's becoming a really serious issue. Like when it's serious, it's very much there. I think interestingly, like I always use it as a joke at the start of my talks sometimes, where I might disclose parts of my identity in order to give context to a talk, or perhaps ask people to ask questions with compassion, especially things around gender identity and experiences like that, and try and like caveat some gentler questions. And I always make a joke about my problems with mobility that I've experienced in the past, because like for the listener, I'm currently wearing like some leopard print heeled boots, and
Fabulous,
right? Like the look is a sleigh, like it's good. But people will hear that I have joint problems or arthritis, and then I can see the room look at my shoes, and I always have to be like, and I'm also allowed to make unwise decisions as a disabled person. So yeah, I know these are gonna make me be in a bit more pain this evening, but it's a trade-off because I look great. So that's my decision, right? I choose that. So I think that's where I feel the fakeness coming in. That's where it's like, but you're choosing to do this. Like you're choosing to go and do that where you know it's gonna cause you pain. Or like I can say to people, yeah, my hip's been really bad recently, but they're like, but didn't I see you at that event? And I'm like, yeah, because I don't want to spend my whole time living inside. And I can sit down for an entire day and end up in pain, and I don't know why. Maybe it's the position I sat in, I don't know. The pain will still be there. I can't live my life controlled in that way. So yeah, I will still go out and I will struggle and it will be difficult, but I'm not going to not do it. But it's almost feeling like you have to play the sick role, right? It's
Right,
almost,
you have to suffer, yeah.
Yeah, if you're not withdrawing, and this goes back to the idea of capitalism and productivity and everything like that, but like, how dare you be outside having fun with friends and family and loved ones when you're not able to work?
Right.
Like, you should be prioritizing work over anything else. Like, are you struggling on Monday? Well, why did you go out for that walk on Saturday then? Because you should have been ready for work on Monday.
I felt like that a lot when I was off sick. So like when I was
Yeah.
first unwell, I was like, I can't, I've got to go to the supermarket.
Yeah.
Like, I've got to make an effort to prepare some food, even if I don't feel like it. And so, but even when I was out, I was constantly worried about being seen by somebody and being judged. Well, you know, if she can do that, why isn't she at work? Why isn't, you know, that shouldn't, not even a priority to be out in the world or to be seen, to be taking care of yourself in any way that isn't a very kind of narrow definition of sickness and illness.
Yeah, 100%. And I think there's sort of related to this idea of faking it. So as someone who, I don't have a neurodivergent diagnosis, and part of that is because, as I said this morning, I have to like organize myself enough to get a referral. And I'm not there yet. It's only been like 3 years. So give me time. And one of the things that I get a little bit anxious about, though, is the association of autism and neurodivergence and gender, and how a diagnosis may be used to invalidate my expression of gender because in some way autonomy is removed from gender diverse people when they also disclose autism or neurodivergence. Like, especially, I mean, this is especially true of younger people, but like as if they don't have any autonomy or right to decide what their identity is simply because there's another
It's like they
thing
don't have
that goes
capacity.
on.
It's
Exactly.
like they assume that autistic people have a reduced
Yes.
capacity to express gender in the way that.
So that's been a barrier for me trying to like worrying about accessing like referral and things, is because I don't know if I want those two labels associated with each other, because there's
The harm
a
it might do.
buttload of stigma I'm going to have to take on to do both of those.
The relevance of the question became even more evident when we discussed mental health-related disabilities and the disconnect between the culture of medicine and the importance of self-care. The culture of medicine often does not prioritize or support self-care, leading to significant consequences for those who try to care for themselves.
Yeah, I think that is definitely true of the idea of these less apparent disabilities, the burden of proof, right? That can be a massive issue, as you said earlier, Lisa, about like the need to prove like a depression or something like that. But I think it's really interesting that the process of like healing for a lot of that is about re-engaging with society, and it's about having fun, and it's about experiencing love again, and it's about all those connections that you need to re-establish in your life when you've either been physically or mentally unwell or whatever. You need to rebuild that. And for that rebuilding, for that healing to be part of the like stigmatized issue of, well, how dare you be doing that before you return to work, I think is really hard. And I think was very prevalent in NHS and medical culture because of this thing around, you're letting the patients down, you're letting your team down, right? We're going to have to find a clinic, someone's clinic's going to have to cover you, all of that kind of stuff. Like, how dare you not prioritize that first? As if it's not a job. Like, it's a job. It's not a calling. I don't care what people say. It's not a calling. It is a job that many of us do very well, and many of us could do better or could still be doing if we have been given the circumstances to allow us to balance different bits of our lives and be able to enjoy living in a social way and also being able to work. But I couldn't do both. I couldn't fulfill the demands of the workplace where I was working 20 or 30 hours some weeks more than I should be, and also be able to enjoy my home life and be able to maintain my physical health and my mental health.
But there's the judgment for not putting work first, right? Like that's where everybody's priority should be. I mean, I felt a lot of shame and guilt around that and making the decision to step away and to leave. I felt so relieved when I put my sort of like resignation letter in for my clinical job. But yeah, like to get to that point it's just horrific.
I often get like one of the things a lot of people will sometimes say to me is, "Oh, it's such a shame that you left medicine."
Yeah, I know.
And I'm like, it's a shame for them.
Yeah.
Not for me.
I
I would be dead.
Yeah.
Like, wouldn't be alive today. If I'd stayed in the NHS, I wouldn't be alive today.
And I actually don't think that's a dramatic statement
It's
at
not
all.
at all.
I think that for many people, that is a fact. I think medicine, the training to be a physician is lethal in many ways.
There's only so many times you can get that close and not follow through. And I had to think about what are some of the drivers that are pushing me there, or what are some of the circumstances which prevent me from being able to step away and heal. And unfortunately, a discompassionate employer, one that felt like it stigmatized it. And I'm not free of stigma in the current world of academia. It's still very much present, but I at least have more control over my time, and I'm able to like protect myself a little bit more. My disclosure of struggling isn't framed as if I'm going to be dangerous to students. Right? So I can disclose in a way that means I can still participate a bit in work, but I can still do more healing, and I can balance those things out. Last week I had a very difficult flow of my arthritis, and I put on my out of office, I'm currently experiencing a lot of pain and a flare from my arthritis. My replies to you will be slower than normal, because I'm in a situation now where I can do that. That never would have been possible in medicine. They don't allow for that degree of accommodation.
What are the opportunity costs when you have an invisible disability? What are the things that, where are the points where you think, if my disability was visible, and for you, you've had both experiences, Megan, if my disability were visible, this would not be happening right now? And we've talked about a few, but are there things that I'm missing?
One of the things for me was when I returned to work, not everyone knew that I'd been off. Not everyone knew, obviously, it was what I had experienced and been through. And there's a lot of stigma still around mental health in the NHS. And I worked a psychiatry job, and there was just something, and some of the things that were said, I was like, you're talking about me. You don't know you're talking about me, but you are saying awful things, really stigmatizing things, using, bad, like terrible language to talk about these patients that you are frustrated, quote unquote, frustrated with. But that's me. And then you don't feel safe. You don't feel part of the team. You don't feel like you belong to that environment. You're not really fully belong to the patient community either, because you're seeing this side of things. And I'm fairly reluctant in general to seek medical intervention now, because I'm so, like, for me anyway, like having seen some of the really poor instances of how people are treated, and the stigma and the worry, like I'm now somebody who lives with chronic pain, and to be given a chronic pain label was something that I also really struggled with, because I knew what clinicians often said about people with chronic pain. And so to be then given that label and think, well, when I'm acutely unwell, that I've been brought in for treatment and I'm in pain, no one's going to believe me. But to know that, like, it puts me off seeking medical treatment. Like, I had sepsis a few months ago, and I had to be taken by an ambulance to hospital because I was just like, it's that classic sort of medical thing actually of just thinking that you're fine, but and not being fine, but also that worry of like, what's going to happen to me when I'm in that system, and I know how awful it can be to be a patient in that system, or how patients are spoken about and treated. So that's sort of how it manifests for me, I think.
Yeah, I see that in education as well, though, like the way that reasonable adjustments and accommodations for learners are talked about is really interesting sometimes. And this has happened on multiple different issues of like talking about students who've experienced abuse, talking about queer students, talking about students with disabilities and stuff. There's often this language, they are a burden, right? And this is the whole idea of reasonable adjustments, the debate. Well, let's figure out what's reasonable for us to do in this situation.
Right, and whose definition of reasonable is that?
And it's really hard to like have to sit there and remind people, and I know trans and non-binary colleagues who experience this a lot, and I suspect it's very true of disabled colleagues as well, but to remind people, we're in the room, right? Like, this isn't just a student issue. Like, we're here in the room with you whilst you're talking about this. My therapist is constantly sort of saying to me about the need to, like, hold back. Like, do you have to share? Do you have to be the one who is putting yourself out there, who is sharing this, who is doing that?
And often has to do the work as well, then the work of that falls to you.
And take on all the cost of that. And I often say, well, no one else is doing it. And my students need a role model. They need to be able to see that there is a visibly queer person. Like, I dress visibly, this outfit, the pain that I said these shoes will cause me later, in part, it's because I like the way it looks, right? It makes me feel good. But it's also because I don't see visibly queer people at this conference. So I want to be making people uncomfortable with my gendered presentation, because this should be a space in which we're allowed to be presenting. And then next year, if a student or a colleague feels more comfortable to wear something, great. But there is a cost to me doing that, right? There is a cost to me trying to role model that space, to be the one who says, can you remember actually that those of us who've experienced abuse, or those of us who have been through that process, are in the room with you now? So I think that's probably the opportunity cost I experience a lot, because I'm also protected by other privileges of my whiteness, by, if I want to, my perceived masculinity, by ways that I can mask or present myself right, that can navigate other possible opportunity costs. Like, I do not experience the level of disadvantage that someone who was a Black queer person would be experiencing in my role at all, like nowhere near that. So I'm very aware that my opportunity costs and other people's ones would be radically different. And so there's a lot of privilege that comes with that. But I think trying to create space, trying to open up conversations, there's a big cost involved in that.
I don't think I realized how unsafe it was for you until we were both in a foreign country and you were coming to me and you told the driver you were meeting your girlfriend.
Yeah.
Because it's like this unknown space. And I'll never forget that, because I thought, that is how, as a woman, sometimes you feel in other countries or in spaces that you're not familiar in. How do you navigate? And that fear. And I think at times that's how people with disabilities feel as they're navigating the different parts of medical school. I don't think we fully appreciate the fear and how much fear there is about safety.
So it's about how vulnerable you are in public and how vulnerable you are with people. Using a visible walking aid, puts Megan in a position of increased vulnerability, right? Associated also with your feminine presentation, there's a higher level of vulnerability. I will choose the outfit that, like when I was at a conference a while ago, someone said to me, "Oh, I thought those nails are quite quiet for you," or something like that. And I was like, well, yeah, that's because I'm in a foreign country and I don't have the support networks for when I'm hate crimed. Like,
I can remember you changing
Yes,
outfits
yeah.
between events, or to walk between events because you didn't know how safe the streets were.
Yeah. And then, okay, fine. So I've got that element of my presentation. But how much more vulnerable is it then when they can see my limp, right? Like, now I've got a physical vulnerability along with it. Now I'm easier to hurt. Now I'm easier. So like, when my hip is bad, I'm very aware that my vulnerability, the visibility of my vulnerability has increased. So I think that's one of the things, maybe the privilege we talked about earlier about the invisible, right? Is that like maybe the vulnerability is different, because when people can immediately tag you as different or in their eyes weaker in some way, like they've already got something they can use against you. And I'm very aware of that.
And the cognitive load, I mean, just to listen to you describe what you go through and to listen to what you've described as, people who haven't seen you are now asking if it is a huge cognitive load to have to constantly answer questions about your wellness. Fear of being taken advantage of because you have a visible mobility.
It's that benevolent ableism that we've spoken about before.
Yeah, and it's to decide how hard to go in the response. Like when people started asking me that question, I'd be like, I didn't really know how to respond, but just try and sort of brush it off, or do you, do you pick them up on it? Do you, and there's only so much of that I have energy to do.
It'll take all of your energy.
And then you worry about your career as well. Like, you know, you're trying to make this is a professional space, you're trying to make connections, you're trying to make a good impression. If I start going around and, you know, if I did that for everybody who asked me, some of these people are pretty influential. And what's that going to do? You know, you worry about what that's going to do for your career prospects. And I want to be somebody who has the confidence and the, you know, and I do have a lot of privilege to do that, but it's just taking time to get to that space where I feel comfy enough.
I want to allow time for questions.
Yeah, I mean, I guess firstly I just want to say a massive thank you for sharing everything that you've shared, because you've taught yourself about the barriers and the stigma to that, and it's really, really brave, and I feel very grateful as a non-disabled person that there's people like you that are willing to do the work, as you've said. So that's kind of where my question comes from, really, is as a non-disabled person, how can I be an ally, and what can I do both on a day-to-day pragmatic level? You know, we're going to have a meeting, what can I do on a pragmatic level to help, but also how can I help with this more society, cultural, political shift, and how do I do that in a way that elevates disabled voices without requiring you to do all the work? Because that's something that I really grapple with, is like, I want to help, but I don't want to put it all on you. Do you know what I'm getting at?
Mm-hmm.
Well, first of all, a lot of people stay in this state of kind of static because they're afraid. They don't know what to do. They're afraid. And they don't, for those that are aware and maybe are allies in other spaces, they also recognize that they don't want to take over, right? We don't need a savior, so they don't want to take over that space. So what advice would you have?
I mean, I think for me, and I think that it would differ depending on the disabled person that you're interacting with in terms of how much support that they would want from you. But I think having open conversations about that, or trying to signal in some ways that you're willing to have those open conversations is helpful. I mean, from like a meeting point of view, one of the things, it's a tiny thing, and I'm not sure how much of a difference it makes, but having my email signature about if anyone is booking in a meeting with me, if they need anything in advance, or if there's anything I can do to try and make that more accessible for them, then, you know, please let me know. And I don't know how effective that is, but I hope, you know, we talked about signals, one of those small signals that I'm open to this conversation, if that's something that you want and that you're sort of willing to have. It's been quite quiet support that I have found the most helpful. I'm just thinking, even in the context of this conference, I've had people offer to help me who've made a really big show of it. Like, they want me to like gush over and like be really grateful for the support that they've given. And also they want other people to see that they've offered to help me up the stairs, or they've offered, you know, to take my bag, or to do X, Y, Z. But then when they've gone, and I've said, no, thank you, because I don't want to gush. I don't want to give all of that gratitude. That takes a lot of energy too, right? When they've gone, there's often been one person or one or two people who've just sort of quietly stayed and been there, been present, and I've been able to turn to them and say, well, actually, you know, it would be quite helpful if you took my bag, or they've just sort of quietly just walked with me. And I think it's that walking with, you know, kind of alongside somebody and being present and available and there and open to that conversation that for me has been helpful. But I appreciate for different disabled people, that support might look different. I mean, on the societal level, that is such a huge question. I'm not really sure how to eradicate capitalism might be a start, but as an individual, that's a huge task.
I think that's such an interesting question. So the first thing I would say is I find the phrase as a non-disabled person really interesting, because unlike a lot of protected characteristics, perhaps, you will be disabled at some point. That will happen. We all become disabled at some point. And so it's worth remembering that as part of this conversation. This is not an identity you will be free of, right? This will come your way at some point in your life. I would approach this in the similar way I approach to a lot of allyship conversations, which is, first of all, you don't call yourself an ally. You are called an ally by the people that you are allying to. They give you that title when you demonstrate that your actions have created the circumstances of allyship. And that is not a permanent title. That is a title you earn every day in your actions going forwards. It is an action. It is a doing thing. I get very annoyed when people say, oh, because yeah, that was quite bad allyship. What do you mean it was bad allyship? It's just not allyship, right? It's not bad allyship. It's not allyship. Or they're like, it's quite passive allyship. What is passive allyship, right? No, be active, because it is that. But I would say for me, like, one of the most powerful things I think that you can do is give somebody power. So to say to them, just let me know if there's anything I can do. Like, I'm very happy to help if there's anything that you need. Just give me a shout. And give them the opportunity to say to you, yes, actually that would be very helpful if you wouldn't mind. I think that you said invitation. Invitation's a really important thing. And you might want to directly ask. You might want to say, would you like me to carry that for you? Or would you like me to do that for you? Would you like me to open that?
But not doing something without consent, because that's
Yes.
the other thing, you know, just like, you would be surprised at how people want to manhandle your mobility aids.
Wheelchair users that will talk about how somebody will push them
yeah.
without their permission, right?
Yeah.
I would add one thing, if I can, and that would be, don't co-opt stories, because you are doing research. I feel like being transparent about the population, thanking the population, if your work is disability informed, maybe even offering scholarly opportunities to the participants to be part of a paper, that is something that I just feel really strongly about, is that all disabled scholarship should include disabled people. And so that's one thing that I would add. And I think sometimes when people talk about disabled people, even in the efforts to be an ally, it is co-opting the story in many ways. Joe, you said, ask if there's something that you can do. And I would say find a way to allow disabled people to tell their stories, and in the way that you present your data, or in the way that you work through presenting your dissertation. You know, whether that be having people voice the quotes that they're doing, or naming them if they want to be named, right?
But I think the opportunity to choose another name so that they can identify themselves.
And there's something about knowing that you're contributing to the collective knowledge and hopefully the policy change that comes as a result of that work.
We spoke a little bit earlier about the idea of like boundary setting, and I think it's this relates to something that a conversation we had before, which was where you shared with me your change of pronouns, and one of the first things that I responded with was, in what spaces would you like me to use that?
Right.
Like when and how would you like that to be done? So like, I was very cautious of giving you agency in how these things are perceived. So I think just think about agency, think about like how you can be removing it from people and giving it to people.
And that was obviously because Joe is excellent, an excellent human being. That was a lovely conversation. I didn't feel uncomfortable. I've had conversations about my change in pronouns that have been like, oh yeah, but like, well, why did you do that? And like, exactly how do you identify? And like, how did you come to that? Like really digging in, really digging in. And uncomfortable, lots of blushing. I'm very awkward. Like, how do you respond to that? And like Joe said, it's respecting, I guess, someone's boundaries. And it's not always, we are curious, I think, as people. We're humans, are curious, but you've got to hold back. It's not appropriate at all times to do that.
Also, like you said earlier, right, that you've put a lot of money into your walking stick.
Yes.
Right.
Right.
Like, go like, oh, cute stick.
Yeah,
Like,
I love
give
that.
give
I
a
love
compliment,
that. No,
right?
I love
Like,
that.
don't be scared of mentioning things.
And on the positive
where, like,
side, some people this conference have complimented the stick, so
as they
to
should.
appropriately represent the positive
for
acknowledgement.
The listener, very glittery.
Right. Yeah. It is. It is like transparent with bubbles.
Yeah.
Yeah.
It's very cool. I guess as like a final thought on that, one of the things would be to be aware of your privilege and how you can leverage your privilege to create the spaces for accommodations to exist without someone having to request them, so that spaces and people are proactive in their approach to disability or other forms of work. Often my work is within equality or equity, diversity and inclusion, and I say I hate the word inclusion. I always have, because inclusivity work often relies on a degree of conformity, a degree of being quiet, a degree of accept what you're given. So I would say to you, what I want you to be doing is not just thinking about what would you be doing to include people when they need to be included, but what are you doing to look at and challenge the principles of exclusion that are stopping disabled people being in the environments, or disabled learners being in the environment in the first place. Because if you wait for people to be there before you're an ally, then it's too late. Those people have already been locked out of that space.
I don't know if I've shared with you my story about the cohort, that there was an individual who was hard of hearing who requested captions. And because the individual wasn't deaf, they were giving that person a really difficult time about getting captions. And the entire cohort decided to request captioning. And
I love
basically said, we're not going to let you do this fight, and said, we're not going to operate in a system that is inaccessible. If it's inaccessible to one of us, it's inaccessible to all of us, and use not only their individual privilege as non-disabled students, but their collective privilege, which I think is something that we don't talk about enough, to create pressure on a system to become accessible for that learner, and because they record lectures for learners moving forward. Well, I want to thank the Association for the Study of Medical Education for inviting us to partake in this talk. I want to especially thank my colleagues and friends for their genuine and thoughtful comments today. And I know this isn't the first time we've talked in a recorded way. You created a poem for our podcast, so I want to really encourage listeners to go back and listen to this incredible poem. And it won't be the last time, because I really want to capture, if you will allow me, your individual stories, the entirety of the story, as we think about ways to disrupt medical training and reshape and reform it. But I'm so grateful for both of you and the knowledge and wisdom you've shared today. And we can announce that we just had a SIG for ASME approved. And so that SIG will focus on disability communities across different health professions, all looking at disability inclusive work. And that'll be an exciting addition to next year's ASME in Edinburgh, which is very weird for me to say, because
Edinburgh.
I don't know
Very
if you've
weird for us
noticed,
to
but
listen to.
it's also not spelled that way.
No, it's not.
But I will be there. I'm a guest in this country, and I very much appreciate being welcomed at this conference. But this is literally the shining star of conferences that I've been to internationally. I love it. I will be back next year. And I hope that our listeners take a moment to check out what ASME is and think about coming and presenting. I encourage you to check it out.
ASME.org.uk, yeah.
ASME, ASME.org.uk.
Yeah.
So check it out. There's so much content there, and just a great organization and an incredible conference, I think we can all agree. So thank you both so much.
Thank you. Thank you for giving us this platform.
Yeah.
Thank you all for joining us for this engaging and insightful discussion. I want to extend my deepest gratitude to Drs. Megan Brown and Joe Hartland for sharing their stories. Please be sure to check out their curated disability content in the journal Medical Education. The conversation we had today really underscores the need for radical change in medical education, for the goal of creating safety, creating expertise in clinical accommodations, creating policies that protect disabled trainees and clinicians, and the need for all of us to think about what we say, what we think, and how ableism impacts our actions and the experiences of others. Remember, as we continue these conversations and take actionable steps towards real change, that we are paving the way for a more equitable future in medicine. If you enjoyed this episode, please share it with your colleagues and join us for our next episode, our 100th episode, where we've interviewed Dr. David J. Skorton and Amy Adams from the Association for American Medical Colleges, and Mi Tien Nguyen, an emerging superstar in academic medicine, where we'll discuss wellness at the intersection of marginalized identities. This podcast is a creation of the Docs with Disabilities Initiative, supported in part from the University of Michigan Medical School Department of Family Medicine M-Disability Initiative, the Stanford Medicine Alliance for Disability Inclusion and Equity, and the Ford Foundation. The views expressed in this podcast do not necessarily represent those of the hosts, their respective institutions, or the sponsors. This episode is released under a Creative Commons Attribution, Non-Commercial, Non-Derivative license. This episode was produced by me, Lisa Meeks, with the valuable assistance of our audio editor, Jacob Feeman. Thank you so much for listening, and don't forget to subscribe.